In this talk, I will present epiretinal proliferations in pediatric age. Epiretinal proliferation in pediatric age are rare entities, and the differential diagnosis can be difficult. I will show you possible clinical pictures. Also, we know that children do not report visual defects, and so this clinical picture might come to our attention relatively late or just by chance, and literature is poor on the subject due to the rarity of the topic. In the differential diagnosis, we should consider first the combined hamartoma of RPE, retinal pigment epithelium, and the retina. It is a benign tumor with combined tissues coming from RPE, retinal vasculature, and glia. It is usually peripapillary in position, and it has pigmented tortuous vessels in the retina with epiretinal proliferations, and involves young people with a mean age of 15 with no sex and race predilection. Usually it is reported for decrease in vision, and at the OCT we can see vitreoretinal traction with the epicenter in the center of the lesion. The therapy can be observation, but in symptomatic patients surgery can be considered. There are surgical reports restricted to around 100 cases, which suggest some benefit from peeling and removal of the lesion itself. Then we have to consider retinal astrocytoma. It is a benign tumor from retinal astrocytes. It's even more rare than the combined hamartoma. It can be a single new lesion, or it might appear as multiple small lesions in one or both eyes. At the OCT, it can be seen as a superficial lesion with a thickening of the inner layers and cysts inside the retina, and it is asymptomatic most of the time. Then we consider in the differential diagnosis the retinal capillary hemangioma. It is a benign tumor. Retinal vasculature is the structure of the tumor itself, and it is part of the von Hippel-Lindau syndrome. It appears in patients around 30 or 35 years of age as a reddish exophytic lesion with an afferent and an afferent vessels that usually are very well detectable, apparent. And the therapy is photocoagulation or cryoablation of the lesion itself, that most of the time is peripheral, but it can leak and then induce visual loss. So here I would like to present you two cases that are suspect combined hamartoma of retina and RPE. You will see a different management, but with a very similar outcome, and this makes them even more interesting. So the first case is a 6-year-old girl that came to me with vision 0.1 with the diagnosis of epiretinal membrane. This was the appearance at the OCT. You can see the thickening in the retina, the folds in the retina, the epiretinal proliferation. And if you look at the color picture, you see some pigment around the lesion that is grayish at the top of the thickening in the center of the macula. So the question, of course, is what to do, and the issues are many. So she's 6 years of age already. Is her level of amblyopia so advanced that gain in vision is already impossible? The surgery, is it more difficult in children? Will I induce the cataract? if it is a retinal hamartoma, will it be possible to peel the lesion, or will it be more dangerous? In this case, I decided to do surgery. And you will see in the video that the epiretinal proliferation could be peeled. I attempted an histological analysis, but the amount of tissue was not enough, unfortunately, to reach a proper diagnosis. So I inserted trocars. She is 6 years of age, so she can be considered an adult in anatomy. I left the trocar at 3 millimeters from the limbus. So the detachment of the vitreous is always expected, very difficult in children, but you can see here that I can pull the vitreous, detaching it from the posterior pole fairly easily. I don't think it is advisable to pull the vitreous in the peripheral part of the retina, because there are no peripheral lesions and we don't want to induce them. So I decided to stain to be able to detect the best that I could the epiretinal proliferations. And you will see that I could grasp with the forceps the grayish tissue, and you see some retinal folds that will unfold when the epiretinal tissue is removed. Sometimes you might have the impression to peel the retina itself. So you have to be very careful and go extremely slowly, but then you can find a plane that will show you how to dissect the epiretinal proliferation from the retina itself. So here I was staining the internal limiting membrane, hoping to have a better guide of the plane of dissection. I was not aiming for a very wide ILM peeling, but it came out that way. So I completed the peeling most of all to help me separating the epiretinal tissue itself. I could see some microhemorrhages, so I was actually afraid to damage the retina itself, but then as you can see, the tissue is coming, and I have the impression I am not damaging the retina, although I would have loved to have intraoperative OCT to have any sort of confirmation. So then I stopped and I switched to air, and I decided to close the sclerotomies with diathermy. But since she's a child, I decided to close it with a suture as well. So here you can see the evolution of the OCT in the postoperative time. The folds are open, and the fovea is assuming almost normal profile. Actually, I could observe an improvement in vision. Not complete, but 10 months after surgery, she could see 0.5. You can see the wide field fundus photo of the operated and the non-operated eyes. And I think it's very interesting to observe the microperimetry. This is post-operative microperimetry. Unfortunately, I did not have the pre-operative one. She has good sensitivity in the peri-lesional area, with a fixation that is not so stable, and it is on the superotemporal side of the fovea. This is 10 months after surgery. In the other eye, fixation is normal. Let's look at the second case. He was a 6-year-old boy, similar vision at baseline 0.1. With the parents, we decided to patch the other eye, surprisingly obtaining 0.6 vision in this eye. And we decided not to do surgery for a while. You can see 10 years later, visual acuity is still fairly good, 0.7 to 0.8, and the appearance is still the one with retinal folds, and the lesion is unchanged. So no surgery in this case. The parents and myself were not convinced of going for surgery due to the improvement in vision that he had obtained. So recently I performed microperimetry. This is 10 years after the first diagnosis, and you can see a good retinal sensitivity all around the lesion, a decrease in sensitivity on top of the lesion with a good fixation, fairly stable in this case, which is parafoveal. So now let's look at the comparison of the microperimetry of the two cases. On your left, you see the image of the girl after the operation, and on the right, the microperimetry of the boy who was never operated. And they look very similar. What I'm curious to see is how the function will evolve in the girl waiting for a longer time. I'm curious to see whether the fixation will move toward the center of the fovea and what will happen to the sensitivity of this retina, and learning from this if it was worth to do the surgery or not. So in conclusion, different managements led to similar results. Yes, the non-operated boy had a longer follow-up, so we will see what will happen. I'm not afraid of cataract in children. Cataract usually develops after vitrectomy, but mostly in adult patient after 50 years of age. And so the question will be whether even the girl operated with peeling will improve her function, and even more than the boy. And once again, I would like to stress the fact that patching the other eye was important. It had a meaning because it helped to develop a parafoveal fixation that could improve the total amount of vision. These are rare cases, and so I think that any case report makes a difference.